Hello, my name is Julie, and I will be presenting the nursing management of acute intracranial problems and intracranial pressure. At the completion of this module, students will be able to identify the common etiologies, clinical manifestations, and collaborative care of the patient with increased intracranial pressure, describe the collaborative and nursing management of the patient with increased intracranial pressure, describe the assessment of the patient's level of consciousness, and describe the nursing management of the patient with a head injury. Increased intracranial pressure is defined as pressure exerted within the cranium by its contents, which include brain tissue, blood, and cerebral spinal fluid. The normal intracranial pressure is 5 to 15 millimeters of mercury. Pressures higher than 20 millimeters of mercury are considered increased intracranial pressure. Increased intracranial pressure impairs perfusion of brain tissue. Impaired perfusion could lead to brain damage or death of brain tissue. Early recognition by nurses is critical. Increased intracranial pressure is not a disease, but rather the fallout from insult to the brain. In adults, the intracranial compartment is comprised of the rigid skull, which houses a set amount of fluid and tissue. Normal transient elevations with a sneeze, cough, or defecation can usually be accommodated. Cerebral perfusion pressure, or CPP, is the pressure of the blood normally flowing to the brain. Normal CPP is approximately 60 millimeters of mercury. 40 millimeters of mercury is considered incompatible with life. To maintain the cerebral perfusion pressure, monitor the mean arterial pressure, or MAP, assess for volume loss like bleeding, administer IV fluid as ordered. Inotropes or vasopressors may need to be given to lower the pressure, as well as calcium channel blockers to prevent vasospasm. The Monroe-Kelly hypothesis states that the bony skull is like a rigid box and cannot expand. When one of the three components increases, the other two must decrease in volume to compensate for the total brain volume and intracranial pressure to remain constant. Let's talk about the causes of increased intracranial pressure. The effects of increased intracranial pressure are proportionate. They may be localized or broader and include seizure, stroke, or death. Cerebral edema is an increased volume of brain tissue due to an increase in capillary permeability. Cerebral edema can be a result of brain trauma or from non-traumatic causes. Cerebral edema can occur in ischemic stroke, cancer, or brain inflammation due to meningitis, encephalitis, and ischemic or anoxic states like acute liver failure, hypertensive encephalopathy, pseudotumor cerebri, and hypercarbia. Changes in structure or function can cause an increase in intracranial pressure. These would include things like subdural hematoma or epidural hematoma. Tumors, whether malignant or benign. Remember, however benign a tumor may be, the space it occupies can cause damage. Strokes or aneurysm where the brain is still intact. Contusions or traumatic brain injury as in accidents or assaults, and abscess. Obstructions to CSF flow and/or absorption can cause an increase in intracranial pressure. This would include hydrocephalus, Chiari malformations, meningeal disease, whether infectious, hemorrhagic, or cancerous. An increase in venous pressure can cause an increase in intracranial pressure. This would include venous sinus thrombosis, heart failure, and any other venous obstruction of blood flow from the brain. Traumatic brain injury is damage to the brain from an external mechanical force not caused by neurodegenerative or congenital conditions. The 15 to 24-year-old age group is at the highest risk. Males have twice as many TBIs as females due to prior head trauma. Falls are the most common cause of TBI in older adults. When the brain suffers a traumatic brain injury, the subsequent swelling or bleeding leads to increased intracranial pressure. Because there is no room in the skull to expand, intracranial pressure continues to rise. Pressure on the vessels within the brain causes blood flow to slow, causing central hypoxia and ischemia, further elevating intracranial pressure. At this point, the brain may herniate, central blood flow ceases, and death can occur. Basilar skull fractures occur at the base of the skull, extending into the anterior, middle, and posterior fossa. A cerebral spinal fluid leak may result, increasing the risk of central nervous system infection and increased risk of hemorrhage caused by damage to the internal carotid artery. Cranial nerves 1, 2, 7, and 8 may become damaged. The patient may have evidence of battle signs such as mastoid and/or periorbital ecchymosis, drainage from the nares, rhinorrhea, or from the ears, otorrhea can be tested for the presence of cerebrospinal fluid. This can be done by first testing the drainage for glucose, and then for the halo sign by dripping fluid on a clean gauze or towel. The bloody drainage will coalesce in the middle, leaving an outer ring of cerebrospinal fluid. And the bottom lower corner is what the halo sign might look like, and above that are links to pictures so that you can review what battle sign might look like. The CT image on the left shows an epidural hematoma with arterial bleeding into the space between the dura and inner skull, demonstrating associated mass effect on the frontal lobes and a slight midline shift. The CT image on the right is an acute subdural hematoma with venous bleeding in the space between the dura and above the arachnoid, with substantial mass effect or displacement of brain tissue. Intracerebral hemorrhage is an accumulation of blood between the brain tissue that could be potentially devastating, producing brain edema and increased intracranial pressure. A brainstem hemorrhage, typically caused from a blow to the back of the head, fractures, or torsion injuries, have a very poor prognosis. Meningitis is the inflammation of meningeal tissues. The mechanism of infection could be viral or bacterial, meningococcal or Neisseria meningitidis, and may occur with skull trauma. Meningitis increases the cerebrospinal fluid production, which can lead to an increase in intracranial pressure. Clinical manifestations include nuchal rigidity, photophobia, fever, headaches, nausea, vomiting, and Brudinsky's or Koenig's signs. The manifestation of increased intracranial pressure, regardless of cause, can be based on the location and extent of the tissue involved. Early signs include changes in level of consciousness. This is frequently the first sign. Changes in speech patterns such as slurred speech or clear speech that don't make sense. Changes in sensory motor and motor function. Pupillary changes like dilated, non-reactive, or constricted and non-reactive pupils. Cranial nerve dysfunction, ataxia, seizures, severe hypertension, and abnormal posturing. Cushing's triad is a response to increased intracranial pressure that can cause brain tissue death. It is a late sign, so if you're seeing it, it may indicate that you've missed something along the way. Cushing's triad includes three prominent signs: increased systolic pressure while the diastolic pressure remains the same, a widening pulse pressure. For example, the blood pressure is 170/50, and then you check on your patient a few minutes later and it's 180/40, and then later it's 200/20, and you can see there's a widening pulse pressure. And lastly, bradycardia is a heart rate below 60 beats per minute. ICP can be measured with a ventriculostomy. The catheter is inserted into the right lateral ventricle. The ICP is measured through the transducer. The ventriculostomy facilitates sampling of cerebrospinal fluid. Intraventricular medications can also be administered. With a ventriculostomy, there is a major risk of infection. When obtaining the neuro exam, an accurate history should be obtained. This patient may be amnestic to the event, unconscious, or confused. The history could be obtained from the first responders or witnesses. Always ask when, where, and how the injury occurred, if the patient lost consciousness and for how long, if there was any seizure activity, or if the patient has any previous history of seizures, and circumstances of any falls, particularly in the older patient. Additional information that should be include hand dominance, disorder or injury to the eyes, any allergies, and a history of drug or alcohol use and abuse or neglect. Assessing and maintaining the airway is the first priority. Check the patient's oxygen level and apply oxygen if needed. Monitor breathing patterns for Cheyne-Stokes respirations, central neurogenic hyperventilation, and/or apnea. Mechanical ventilation may need to be initiated if the patient is unable to maintain a safe airway. There are two types of level of consciousness assessments, rapid and complete. The rapid assessment is based on emergent needs and the deterioration of the patient. It includes the Glasgow Coma Scale, level of consciousness, orientation to person, place, and time, movement of arms and legs, and pupil size with reaction to light. The complete neurological exam includes components of the rapid exam, including vital signs, level of consciousness, memory, and attention, also known as a mental status exam. An exam of the pupils, including if they are round and reactive to light and accommodation. A cranial nerve exam, particularly cranial nerves 3, 4, 6, and 7, to assess extraocular movements, and brainstem function. A motor and sensory function exam should be included as well as dependent reflexes and cerebellar function. Ask your patient to show 2 fingers, stick out their tongue, or wiggle their toes and thumb. Have your patient complete simple math, like how much is a quarter, a nickel, or a dime, and to repeat, I went to the store, bought a loaf of bread, and received 50 cents change. An important part of the exam is comparing one side to the other, left to right, to detect subtle changes that can be found in comparison, such as decreased motor function, contralateral changes in motor ability like hemiparesis or hemiplegia. A flow sheet similar to this would be used to document the Glasgow Coma Scale, which is the gold standard for level of consciousness assessment. It measures arousal and cognition. Does the patient open their eyes spontaneously, or to speech, or pain, or not at all? Are they oriented to person, place, and time and the reason for admission, or confused? Is the patient's response inappropriate, incomprehensible, or is there no response at all? Does your patient obey commands, or localize pain, withdraw to pain, flex or extend extremities to pain, or is there no response? Scores can be as low as 3 and as high as 15. With a score of 8 or lower, intubation should be considered if not already done. Any changes in the score should be reported to clinicians. The pupil assessment includes size, shape, and reactivity. The normal pupil response would be equal in size, shape, and reactivity to light unless the patient has had a previous history of surgery, such as cataract surgery. The causes of an altered level of consciousness include brain lesions, strokes, infarcts, bleeds, tumors, and injuries, or metabolic disorders, hypoxia, organ disease, pharmacologic drugs, a vitamin deficiency, electrolyte imbalance. The most common causes in the hospital include hypoxia, hypoglycemia, a sedative drug overdose, or delirium. This is posturing. The patient at the top of the picture is an example of decorticate posturing, which includes plantar flexion, knee extension, and arm-hand flexion, indicating there's an interruption in the corticospinal pathways. Decerebrate posturing is characterized by plantar flexion, knee extension, hand flexion, and arm pronation, indicating brainstem herniation. The two can be distinguished by association of decorticate with the core. Arms and hands are brought to the core of the body. For intracranial conditions, the nursing interventions include maintaining the patient's airway and oxygen, applying oxygen when needed, monitor for change in the level of consciousness and vital signs, monitoring intake and output, monitor for metabolic and hormonal abnormalities such as diabetes insipidus and SIADH, monitor for electrolyte imbalances including sodium, potassium, and glucose, and repeating fluids and electrolytes as needed. You may need to administer mannitol or decadron as directed to reduce edema. Be sure to begin nutrition within 48 hours. Additional interventions include monitoring and maintaining a normal intracranial pressure, maintain the patient's body position, keep the head of the bed at 30 degrees or higher, avoiding neck flexion and extreme hip flexion, provide a quiet environment, avoid constipation and coughing as able, space out care activities, and prevent further injury. Monitor for signs and symptoms of cerebral edema and or brain herniation, including posturing, headache, and vomiting that is usually projectile. Monitor for seizures. Seizure precautions may need to be initiated, including oxygen and suction at the bedside and padded side rails. Monitor and prevent complications of immobility. Turn and position your patient every 2 hours to prevent pressure ulcers. Apply SCDs, ankle pumps, or range of motion. Administer anticoagulants if and when appropriate to prevent DVT and PE. Excellent catheter care of the urinary catheter, and of course remove the indwelling catheters as soon as possible to prevent urinary tract infections.